So I think of products that are liquids, like shampoos, hand soap, dish soap, laundry detergent, as products that could contain methylisothiazolinone. And the biggest offenders were dish soap, shampoo, household cleaners, hair conditioners, hair dye, laundry products, and soaps and cleansers. In reality, MI can be found in many types of products.
That's Dr. Amber Atwater, and this is Dermatology Weekly, the weekly podcast from MD Edge Dermatology. I'm MD Edge editor Elizabeth Mechcatie.
And I'm MD Edge editor Terry Rudd. Today, household and personal care products are common sources of contact allergy in dermatology patients. Dr. Vincent DeLeo talks with Dr. Atwater and Dr. Margo Reeder about the epidemic of allergic contact dermatitis associated with methylisothiazolinone, or MI. It's a common preservative found in many water-based products. Dr. Reeder and Dr. Atwater discuss the emergence of MI as a contact allergen, and they highlight some of the common and lesser-known sources of MI exposure.
In the news, thread lifts are making a comeback in aesthetic dermatology. A small study identifies immune dysregulation as a substantial feature of Hidradenitis suppurativa in African American patients. And Dr. Andrew Alexis discusses topical treatment options for hyperpigmentation in an interview at the summer meeting of the American Academy of Dermatology.
You can reach Dermatology Weekly by emailing us at podcasts@mdedge.com. You'll also find that email address in the podcast description.
And now the news.
Thread lifts are making a comeback, largely because of advances in absorbable sutures. That's according to dermatologist Dr. Ariza Ortiz. Dr. Ortiz is Director of Lasers and Cosmetics at UC San Diego Health. She provided an update on the use of threads to improve skin laxity at the Masters of Aesthetics Symposium in San Diego. Dr. Ortiz says one of the benefits of thread lifts is speed. Results are evident immediately. Thread lifts are used for jawline lifts, cheek enhancement, brow lifts, wrinkle reduction, body contouring, acne scarring, and texturing. Dr. Ortiz explains that patients with moderate skin sagging are better candidates than those with severe skin sagging. For skin lifting, clinicians implant the threads subcutaneously. When tugged in the opposite direction, the barbs anchor in adipose tissue, increasing tensile strength while suspended in the dermis and overlying tissue. That produces a fibrous adhesion capsule that helps to solidify the suture's anchorage long-term. Fibrosis has been shown to increase local collagen production. Dr. Ortiz is co-chair of the Masters of Aesthetics Symposium, where she commented further on thread lifts in an interview with MD Edge reporter Doug Brunk.
Thread lifts have been around since the 90s, and they've actually recently become more popular again because the initial threads were non-absorbable. They were permanent sutures, and so there was a lot of complications from them, like granulomas, permanent dimpling, chronic pain, and extrusion of the threads, and so they really kind of fell out of favor. I think they were also overpromised as an alternative to a facelift, a surgical facelift, and the results just aren't comparable. And so now that we have absorbable sutures, I think they've become more popular again.
What's the price difference for a patient undergoing a thread lift procedure versus other modalities?
Yeah, so a surgical facelift or neck lift can run $10,000, $15,000 or more, depending on who the surgeon that you see. Thread lifts, it depends on what type of thread lift and how many threads, but it can run anywhere from hundreds to just the low thousands. So it's definitely a lot cheaper than a surgical facelift, but like I said earlier, the results are more subtle, which a lot of patients want these days, and they also don't last as long. So, they can last anywhere from a year to maybe 2 years, best case scenario.
Immune dysregulation is a substantial feature of Hidradenitis suppurativa in African American patients. That's according to a small study of 16 African American patients with HS led by researchers at Johns Hopkins University in Baltimore and the National Institute of Arthritis and Musculoskeletal and Skin Diseases in Bethesda, Maryland. The findings appear in the journal Science Translational Medicine. The cause of the painful skin condition remains unknown, but the researchers say neutrophils are prominent in affected areas of skin. Those neutrophils form neutrophil extracellular traps, or nets, that activate immune responses and promote inflammation. The investigators found net structures in the lesional skin of African American patients with HS, but those structures weren't in the skin of control patients, and serum from HS patients didn't properly degrade healthy control nets. The researchers also found a significant link between the amount of nets released in HS lesions and the severity of HS. The results indicate that net formation is enhanced in HS and that net degradation mechanisms may be impaired in HS patients.
What are the best options when choosing a topical treatment for pigmentary disorders? In an interview at the Summer American Academy of Dermatology meeting in New York City, Dr. Andrew Alexis talked with MD Edge reporter Ted Bosworth about the right topical regimens. Dr. Alexis is professor and chair of the Department of Dermatology at Mount Sinai St. Luke's and Mount Sinai West in New York.
Dr. Alexis, here at the Summer AAD meeting, you provide some very practical information about how to handle hyperpigmentation, starting with topical therapies. And I would like to try and capture that. What is the first line? How do you begin?
Yes, thank you. It's a pleasure to be here and discuss my presentation at the Summer Academy meeting on topical therapies for treating pigmentary disorders. So when we think about pigmentary disorders, we have two broad types, hyperpigmentation and hypopigmentation. And topical therapies really are the mainstay, the first line of therapy for both broad categories. Between the two, hyperpigmentation is really the most common set of disorders, including post-inflammatory hyperpigmentation and melasma as being two of the leading disorders. And when approaching the therapy of those common conditions, starting with hydroquinone-based therapy is a typical first line based on the efficacy and safety of doing so. However, from a safety perspective, there's a certain time limit beyond which there are some risk safety considerations when using hydroquinone. Specifically, with long-term use of hydroquinone, the rare side effect of exogenous ochronosis can occur. And so when looking to the literature as far as guidance on how long one can use hydroquinone safely without the increased risk of exogenous ochronosis, there's data to support that using it less than 1 year is a safe approach. In fact, most of the data that we do have supports 6 months of continuous use. So in my practice, I'm comfortable using hydroquinone-based therapies for up to 6 months, after which I will taper or discontinue and transition to a non-hydroquinone-based therapy. As far as non-hydroquinone-based options, we have prescription topicals and non-prescription cosmeceuticals. In the prescription category, we have topical azelaic acid at 15 and 20%. We have the topical retinoids, including tretinoin, adapalene, tazarotene, all of which have been shown to be efficacious in treating various types of hyperpigmentation. And then in the non-prescription category, we have a growing list of cosmeceutical over-the-counter agents that can play a role in reducing pigment. Most notably, we recently conducted a study with one such topical, which is a multimodal topical cosmeceutical called Litera 2.0. We compared it against the gold standard of 4% hydroquinone in a split-face study. And what we found in these melasma patients that we randomized to having one side of the face treated with the cosmeceutical versus the other side with hydroquinone 4% is that we saw comparable reductions in melasma severity at the end of the study with both hydroquinone and the non-hydroquinone cosmeceutical Litera. We also saw comparable improvements in the quality of life impact. So this is one more recent alternative to hydroquinone that's available without a prescription. There's also some emerging data with another topical called cysteamine, 5% cysteamine cream, which works for a variety of mechanisms but doesn't have the same side effects as hydroquinone. And this is something that's been studied in melasma, and we may see increasing use as we get more experience with it. Moving into the arena of where topical therapies alone don't produce sufficient improvement, which is sometimes a common scenario when treating conditions like melasma, where we sort of hit a wall with our topical therapies alone. This is a scenario where I will add in-office procedures, namely chemical peels as a starting point, and in some instances, specific lasers, especially low energy non-ablative fractional lasers. When it comes to chemical peels, I'll typically combine topical skin lightening therapy with low concentration glycolic acid peels or salicylic acid peels. And these have to be done with caution to minimize excessive irritation, which can induce further pigmentary change in a patient of color. Moving beyond hyperpigmentation, we're faced with patients with a loss of pigmentation, such as post-inflammatory hypopigmentation from seborrheic dermatitis on the face. I presented some data using topical calcineurin inhibitors, such as pimecrolimus, to treat hypopigmentation secondary to seborrheic dermatitis, and also discussed some clinical experience using the topical PDE4 inhibitor, crisaborole, for facial seborrheic dermatitis with post-inflammatory hypopigmentation. Another common scenario where we see hypopigmentation is in a condition that mimics tinea versicolor, but is called progressive macular hypomelanosis. And similar to tinea versicolor, it involves the trunk, usually the back, the lower back, the abdomen. But to distinguish it from tinea versicolor is it lacks scale and doesn't respond to antifungal therapy. So I discussed the use of a Woods light to help make the diagnosis, to rule out vitiligo, but also to rule in progressive macular hypomelanosis by the presence of fluorescence of the bacterium P. acnes, which can fluoresce. You can see it fluoresce within the follicular openings. That can help solidify the diagnosis. Because P. acnes appears to be an important driver of that condition, topical therapies directed against P. acnes, such as benzoyl peroxide clindamycin combinations, with or without phototherapy, have been used, and that's typically what I begin with in my practice. Lastly, I discussed the use of topical bimatoprost for the treatment of vitiligo and other disorders of hypopigmentation. And there's limited data using it with some efficacy on facial and non-facial vitiligo, and I've had success in my practice of using that as an alternative to topical corticosteroids, topical calcineurin inhibitors, or sometimes used in combination to get better response.
What you described is sort of a stepped care approach to some degree. And is that true of most patients, or some patients respond to the first-line agents? How much of a moving target is hyperpigmentation? Does it require usually having to go back and try different methods?
Yes, that hyperpigmentation is one of the more challenging disorders, set of disorders that we treat, and it often does require combination therapy to get the best outcomes. So while we start with topicals, I see my patients back after 2 to 3 months of topical therapy alone, at which point we, based on the degree of improvement, can make a decision of whether or not to add either a second topical for additional benefit or an in-office procedure, such as a glycolic acid chemical peel or salicylic acid chemical peel, or in the appropriate patient, a non-ablative fractional laser.
And one last question. Can you return to hydroquinone in a patient after, say, a year or so without using that approach?
Yeah, so when dealing with long-term disorders of hyperpigmentation, such as melasma would be the best example, we often do have to return to hydroquinone after a hiatus. So I'll typically use hydroquinone for up to 6 months continuously if needed, transition to a non-hydroquinone, but then return to it after a 6-month hiatus. So 6 months on, 6 months off, roughly, is an approach that I find useful when needed when treating a longer-term disorder like that. But in addition to sort of sequential therapy, hydroquinone-based followed by non-hydroquinone-based, combination right from the outset of a hydroquinone-based product plus a non-hydroquinone-based product like a retinoid or azelaic acid actually improves efficacy. So I'll often combine even from the outset more than one topical to ensure high efficacy.
And would that include one of the cosmeceuticals?
Yes, it might include one of the cosmeceuticals. I tend to start with prescription therapy, however, so I may use a hydroquinone-based formulation, especially one that is my preferred one based on efficacy and evidence is the triple combination formula that contains 4% hydroquinone, fluocinolone, and tretinoin in a fixed combination. I'll have my patients use that at night. And in the morning, use prescription azelaic acid 15% in a foam vehicle or gel. That's typically what I'll do for the first 6 months. But after the 6-month mark, I want to transition away from the hydroquinone product, and I may replace that with the cosmeceutical that does not contain hydroquinone.
Great. That's very practical information. Thanks for speaking with us.
Thank you. It's a pleasure.
We'll be right back after this message. And now, Dr. Vincent DeLeo, Dr. Margo Reeder, and Dr. Amber Atwater.
Today we're talking to Drs. Margo Reeder and Amber Atwater about methylisothiazolinone contact allergy. Can you both please introduce yourselves for our listeners?
Sure. Hi, my name is Margo Reeder, and I am an assistant professor at the University of Wisconsin.
My name is Dr. Amber Atwater, and I'm an associate professor at Duke Dermatology.
Great. Thank you both for joining us today. So let's get started. So as you point out in your most recent final interpretation column in Cutis, most of our listeners are probably familiar with the preservative methylisothiazolinone, or MI. Can you review the history of usage of this preservative and related chemicals and how it became such a problem?
Be happy to. Methylisothiazolinone, or MI, has actually been around for quite a long time. It was initially found in combination with methylchloroisothiazolinone in a 3-to-1 mixture known as Icahn CG. And that chemical has been around as a preservative for over 40 years. But it was only in the 2000s there was a change to the use of methylisothiazolinone, where this chemical was then used in personal care products alone at a higher concentration. And that's really when we began to see patients being exposed to MI and subsequently developing contact allergy.
What types of agents commonly contain MI?
So I think of products that are liquids, like shampoos, hand soap, dish soap, laundry detergent, as products that could contain methylisothiazolinone. Dr. Andy Sheeman completed a project that looked at which products in our CAMP database that most commonly contained methylisothiazolinone, and the biggest offenders were dish soap, shampoo, household cleaners, hair conditioners, hair dye, laundry products, and soaps and cleansers. In reality, MI can be found in many types of products.
So these exposures represented the most common clinical cases seen in most practices. Can you share the less common exposures in household products reported to cause problems?
So one of the things we've seen reported more commonly in the literature and a problem for patients is actually paint. Particularly the latex-based paints contain a preservative as they're water-based, and those preservatives are also often isothiazolinones. And that can actually, when the paint is curing on the wall, that can lead to off-gassing of MI and can cause an airborne contact dermatitis. Now, there was a study doing some chemical analysis of paints on the market, and many, if not most of these paints do contain MI. But the good news about that is that eventually the paint cures and the MI off-gassing does decrease. Other exposures that we've seen are cleaning products. Lots of different water-based cleaning products contain isothiazolinones, as well as glues. In our article, we also mentioned the hot trend of slime, and that can cause a contact dermatitis from use of some of the ingredients in slime as well.
Yeah, so I'm going to highlight actually the slime one more time. This has been reported several times in the literature so far, but one of the things I wanted to point out about the slime and how this becomes relevant for methylisothiazolinone is it's the ingredients that the families and children are using to mix the slime that contain the problem. So, for example, slime sometimes contains glue, which could contain the methylisothiazolinone, or also could contain a number of cleaning agents that could contain the methylisothiazolinone. Similarly, something called noise putty which is going to be similar to slime that children and families could make, has been reported to contain methylisothiazolinone. And then two less common exposures are something called ironing water, which is a liquid-based spray that can be purchased at the grocery store and is an aid to ironing, as well as methylisothiazolinone has also been reported in a designer eyeglasses frame.
I guess that stuff is all over the place. I understand also that there are reports relating exposure to MI in some cases of sun-related rashes. Can you tell us about those?
Yeah, so this is really interesting. There are two studies that we reference in our paper, but these are not the only reports in the literature. The two studies that we presented discussed patients with dermatitis in what's called a photodistributed pattern. And these patients had accentuation of their dermatitis on the face, the dorsal hands, and sometimes the forearms. Of those patients who had photo patch testing completed, photoaggravation was noted, meaning that methylisothiazolinone was positive on both the non-irradiated and irradiated sides, but it was more positive on the sites that were irradiated with ultraviolet A. In addition, some of these patients had lasting photosensitivity even when they were avoiding their allergens. So because of these and some other studies, I now routinely include MI when I perform photo patch testing.
What kinds of things should our listeners be aware of?
MI is definitely in a lot of different products, as we've already mentioned, but it represents a particular problem when it's in things that aren't labeled to contain MI. Importantly, for industrial chemicals or chemicals that have a material safety data sheet, the methylisothiazolinone may not be present on that because it's often used in a very low concentration, and therefore the manufacturers don't need to include it on the MSDS. Additionally, methylisothiazolinone has been found in clothing. It's been found in plastics and in glue. There was an interesting report of MI being found in glue that's used in shoes, causing a foot dermatitis. So what our listeners should really understand is that if patients are allergic to MI and they're having dermatitis from clothing or being in contact with different types of glues, that there should be a low threshold for considering MI as the source of that.
Now, to make things even more complex, there are two more isothiazolinones out there that we should be aware of. Can you describe those for us?
Sure. So the first is benzisothiazolinone, or BIT for short. This one is not commonly found in personal care products, but has been identified in glues, cleaning agents, paints, and industrial chemicals. The second chemical is octyl isothiazolinone, or OIT. This one is also not common in personal care products, but has been reported in leather furniture, belts, shoes, and watch bands, as well as industrial chemicals.
I understand, as you point out in your article, in order to confirm the allergy by patch testing, you point out it must be tested alone, and that it is not present as such in TrueTest panels. So how should our listeners who use the TrueTest in their practices proceed when this allergy is considered?
The TrueTest does contain a methylchloroisothiazolinone MI mix, but what we know when testing patients for MI allergy is that testing with the mix of MCI and MI in combination can miss a significant number of patients who are allergic to MI. So what I would advise practices that are using the TrueTest is that if you have a patient who has isothiazolinones in their personal care products and you do the TrueTest and the patch testing is negative, I would consider patch testing to MI alone. We do know that patch testing to MI alone can pick up about 40% more patients that are allergic than testing with the combination of MCI-MI.
Well, this has been an incredible discussion of a problem that has affected many of our patients. So are there any final comments that you have for our listeners?
What we know about MI allergy is that many patients are sensitized when when MI is used in a leave-on product. And in fact, there's regulation in the EU that MI is banned in leave-on products, but there's no such regulation here in the US. I think that's important to recognize the role of leave-on products in the epidemic of MI allergy that we are seeing in our contact dermatitis clinics.
So that's an excellent and interesting comment. And so I think our listeners have to understand that MI can be used in what you call leave-on products. That is, things that you don't rinse off or wash off, like shampoos and body washes that are the more common exposures. So we must think about pretty much all personal care products and all the other interesting and unusual exposures that patients may have to this group of chemicals. So thank you both again for a very engaging discussion of a very important problem.
And that's it for this week's episode of Dermatology Weekly. Remember, you can listen to every past and future episode of Dermatology Weekly by subscribing on Apple Podcasts, Spotify, Stitcher, or wherever you get your podcasts. I'm Terry Rudd.
For Dr. DeLeo, MD Edge editor Melissa Sears, and all of us here at MD Edge, I'm Elizabeth Mechcatie. Thanks for listening.